We'll just get started. Okay, good afternoon, everyone, and thank you for being here with us today. And we have doctoral students from the institutes, and I noticed that we also have faculty here with us. And like I told Patrick earlier, the institute is comprised of disciplines from occupational therapy, physical therapy, and clinical psychology and behavioral science. So we have students from PT, OT, with backgrounds in PT, OTs, and rehabilitation science, and psychologists, and they are all interested. They are all interested in interdisciplinary discussions, and I'm pleased to welcome you to the multidisciplinary research in healthcare professional online lectures. And I want to first thank the Institute of Allied Health Sciences for arranging the lectures. And this is part of a series of online talks on health-related topics that have that began 2 years ago since the COVID started. And many of the issues that were discussed in this seminar are discussed from the perspectives of one specific professions, like today's lecture. But I think that from our experiences, we know that the knowledge can be applied across disciplines. And today we are very pleased to be able to welcome Director Patrick Kerr with us. And Director Patrick Kerr has extensive clinical, administrative, and teaching experiences in occupational therapy. And he is one of the pioneer occupational therapists in Singapore, and currently the director and senior principal occupational therapist of Singapore General Hospital Postgraduate Allied Health Institute. And he is also an adjunct associate professor in occupational therapy, Singapore Institute of Technology. And Dr. Kerr has been, I know Dr. Kerr pretty well because we both work we met in many international conferences and have meetings with international organizations. So Dr. Kerr, you can see Dr. Kerr has been dedicated to promoting occupational therapy by working with international OT organizations. He was the president of Asian Pacific Occupational Therapy Regional Group from 2017 to 2020. But he has been working with this organization for like many years. From being a general secretary to being the treasurer and vice president and the president. So he has a lot of experiences in international OTs as well. And the topic today would be the aspect of Singapore healthcare systems that are related to occupational therapy. And I'm very excited that he would talk about the financing aspect, because that's something that we rarely heard in other lectures. And so without further delay, we'll get started. Okay, so Patrick.
All right, thank you very much for the introduction, and thank you also very much for inviting me to share with you this topic on healthcare system in Singapore, as well as how OT, occupational therapy, is involved in this delivery of the health services in Singapore. So allow me to share with you a bit more about my work. Okay, so as Prof. Chang has mentioned, I'm an occupational therapist by training. I still do some clinical work. So my main area of clinical work is in hand therapy and in ergonomics. So I work with a lot of people with mainly work-related injuries and overuse syndrome. So I work with the Singapore General Hospital, which I will tell you a little bit more about it later. And under the teaching arm of the hospital, we have a postgraduate allied health institute, which I'm the director. So in this institute, we run mainly continuous professional development programs for allied health professionals. for physios, occupational therapists, speech therapists, psychologists, dietitians, and so on, and pharmacists as well. On average, we run about 70 to 80 programs a year, including lectures and workshops. And now with technology, we can actually go international. So I do welcome you to actually attend some of these lectures. We have actually monthly lectures, and they are complimentary, accessed through Zoom. So you may access our website to find out more about these lectures. So every month we have different topics by different professional groups. So yeah, you're welcome to join us for those lectures and workshops. And I also teach at the Singapore Institute of Technology, which currently is the only university in Singapore that offers a degree in occupational therapy. It is also the main university for offering allied health programs. So we have physiotherapy, speech therapy, radiography, as well as for dietitian. Right? So it's the main university for allied health training. Okay, so I will skip this as Prof. Chang has already mentioned. So Singapore General Hospital, where I work, is founded in 1821. It is the first as well as the largest hospital in Singapore. So we provide specialist care, and this is a bit some of the information on the hospital. So we have about close to 10,000 staff with about close to 1,800 beds. And these are some of the attendances. Currently, we have 52 occupational therapists, about 100 over physiotherapists, and about 40 speech therapists. Clinical psychologists also is part of our allied health group. Currently, we have about, I think, 20 over 30 or 30 clinical psychologists as well in the hospital. So it is a teaching hospital as well. And this picture is what you see here. So we are constantly changing and rebuilding. So in 10 years' time, that is what you will look like on the picture on the right. So this is the outline of my talk today. I'll be sharing with you the Singapore healthcare system, and then how some of the recent trends and the changes in the health landscape has impacted on our practice. So there are some new initiatives that were implemented recently, which I'll share with you. And then finally, I'll talk about some of the plans that we have, or some of the framework that we adopted recently in the development of allied health professionals, not just occupational therapists, to ensure competencies. So one of the things that we have recently implemented is known as the entrustable professional activities, which I'll share with you in a while. So I'd like to keep the session also informal. So please feel free to stop me if I'm not clear, and feel free to type your questions on the chat box. So I'll try to address some of these questions. I'll try to keep my lecture a little bit shorter so that we have some time for questions and answers later on. Okay, so I'm pleased that the Singapore healthcare system has been quite highly ranked by the World Health Organization. We have one of the highest life expectancy in among the world. So currently it's about 83.5 years, and also one of the lowest infant mortality rates in the world at 1.45 per 1,000 live births. So one of the positive part of our healthcare system is that it is efficient, and the difference also is in this financing. So we are using a mixed system, which is quite different from Taiwan, as I understand, which is a single payment system. So later I'll talk a bit about this payment system, how the various parties are involved in financing. So this is the overall healthcare continuum that we are familiar with. So from health promotion, right all the way to long-term care. So there are different segments where the government had played a larger role. So if you look at this whole continuum here, the government actually is largely involved in the acute and intermediate, especially in the acute care, okay, where the hospitals, so about 80% of the hospital beds are actually publicly funded, okay, with about another 20% in the private sector. The primary healthcare as well. So again, 80% of the primary healthcare, mainly by the general practitioners, are actually done by the private sector. But increasingly, the government is trying to put in a bit more resource in primary healthcare. So we have been having collaboration with the private general practitioners, where the government actually subsidize some of those care in those joint family clinic through some subsidy schemes. And then if you look at the intermediate and long-term care, traditionally these groups are mainly run by the voluntary welfare organization. Okay, but again, increasingly because of aging population, the government is actually putting a bit more resources in this, where the government actually built a few more government-funded community hospitals, and also took over the running of some of the hospital community sectors which were traditionally run by VWOs or voluntary welfare organization. Okay, so if you look at the main players in our healthcare landscape, so there are three sectors basically. Okay, we have the public, private, and the people. Okay, I'll talk a bit more about each of these areas. So in the public arena, so the Ministry of Health has a holding company called MOHH, so the Ministry of Health Holding, which actually has a few clusters that actually comes under it, so with a few agencies as well. So we have three different health clusters, which I'll elaborate in a while, and also three agencies that would provide support work. So if you see here, AIC, IHIS, and ALPS. Okay, so the three health clusters are NHG, which is the National Healthcare Group, HHS, which is the SingHealth Group, and NUH is now National University Healthcare Systems. AIC is an agency that helps to integrate care. We have IHIS, which looked at the National Information System, Healthcare Information System. So our electronic health records, all these are actually coordinated by IHIS. And then ALPS, which is ALPS, that is the agency that does all the procurement of medication, of equipment, so that we get the economy of scale. We have two stack boards under Ministry of Health. So the Health Promotion Board, which increasingly is playing a more important role because we're looking at health promotion and disease prevention. And also our Health Science Authority, which our main work involve providing support for forensic science, as well as our blood bank, and also as a regulatory body for our medicinal as well as medical products. Here we have 7 professional boards and council under the MOH, our Ministry of Health. What is relevant to us will be the number 7, which is the Allied Health Professionals Council. So currently we have, not all the allied health professionals are regulated yet. So only 5 professional groups are regulated: occupational therapists, physiotherapists, speech therapists, radiographers, and radiation therapists. So the AHPC actually provide the oversight of registrations for the allied health professionals, including the supervisory framework for new entrants, as well as overseeing the entry exam for candidates from schools that are not on this approved list. Okay, so just to go into a little bit more detail about each of the health clusters. So we have now 3 main health clusters in Singapore. So the National Healthcare Group, the National University Healthcare, and then where I work, which is the Singapore, the SingHealth Group. So you can see here the Singapore General Hospital as part of the SingHealth Group. So each of these groups are designed to actually serve the regional groups in Singapore. Okay, so you can see from this is a map of Singapore, which is really a small island, and it's divided into 3 parts. So each cluster is supposed to serve one part of the region of this Singapore population. So just to give you an example, the SingHealth group, So we are actually the biggest group. So although we are supposed to serve only 1/3 of the population, but as you can see from these charts over here, we actually serve about half the population of Singapore. And largely because the segment that we serve in the southern part of Singapore, where we have the older age group of people living in, and also a lot of our national specialty centers are also located within the SingHealth cluster. So we actually see more of the Singapore, a larger portion of the Singapore population. And also the Women's and Children's Hospital is also located within this cluster. So that's why we see about 50%, although theoretically we are only supposed to cover 1/3 of the population. Okay, so we provide, so as a cluster, we provide the whole spectrum of care. So HHP here, which you can see here, are the polyclinics. So these are basically providing primary care in the community. And then in the acute and secondary as well as tertiary care, which are mainly our hospital. So we have within SingHealth 4 different campuses. Okay, so the one that I'm in is the SGH campus, where we have also the national centers in the middle here. Okay, so these are National Cancer Center, National Dental Center, National Heart Center, Neuroscience Institute, as well as National Eye Center. Right? And each cluster also have the education arm with a medical school. Right, so the National Healthcare Group has got with Tan Tock Seng, we have with the National Nanyang Technological University, School of Lee Kong Chian, which is a medical school, and then our National University is with our NUS Medical School, and within SingHealth we have a Duke NUS Medical School. Right, so each cluster actually has a sort of a university partner. And then right at the intermediate and long-term care, that's where we have a group of community hospitals, where we also work with community partners, daycare centers, and so on, to provide intermediate and long-term care services. So this is to ensure a seamless continuation for our patient care. Next, let me just share with you a little bit about our financing, So basically, our philosophy is really to ensure affordability and accessibility, and there's also collective responsibility. So this is really to manage or prevent over accessing healthcare services, right? So let me just very quickly talk about these 3 aspects. So a large part of it is actually provided by the government funding. So it's heavily subsidized up to 80% by the government, unless you choose to go private. Okay, then it will be all fully self-funded. If you go on the public healthcare, 80% is funded by the government. And we have also a Medi Fund, which is to help with the needy, those who actually cannot afford. So they actually will have special funding provided for that. Then there is another feature, which is the co-payment feature, where we actually have got compulsory saving account, which we have to tap on. I'll mention a bit more about this later on. And then the government also try to allow market to actually, take the market mechanism to work wherever possible. Right. So if you look at our philosophy, it's actually guided us to develop a hybrid financing system, okay, which is illustrated from this inverted triangle here. So the large part of it is from the government subsidies, and then we have our compulsory healthcare savings that we have to use, and then there is a portion of the insurance. Again, the social, it's in a sense a public run insurance system, and then finally there is Medifund for those who are needy. Right. So this funding model is often referred to as the 3M. So we have MediSave, MediShield, and Medifund. Right. So MediSave is our compulsory health account, which I'll just talk about in a while. Right. So the MediSave, basically every month a part of our salary goes into this account. Right. So it's a compulsory savings. So as long as you're working, there will be certain portion of your salary top up by the employer that goes into this MediSave account, And this MediSave account can be used to pay part of the hospital bill. It can be used to pay for some of the outpatient services, as well as to pay for health insurance. Right. So the next part, which I mentioned earlier about the health insurance part, we call it MediShield. So this MediShield, again, is a state-run insurance scheme where we can use our MediSave account to pay for this. So there's no out of the pocket. Means we don't need to come out with cash to pay the premium. It can be deducted from our MediSave to pay for this. And then finally, MediFund for the needy. So for people who are not working, where they do not have any MediSave money, then they may tap on this MediFund. Okay, so the coming back to our healthcare system, we have actually seen through many cycles of change. In fact, one of the features of our healthcare system is that it is very open to changes, right? So from 1980s to now, it has gone through many restructuring and changes. So before 1980, all the hospitals are state-run, so it's directly under Ministry of Health, right? Then in the 1980s, the government corporatized most of these hospitals. So it's called restructured hospital, to give the hospital more autonomy. So they are given autonomy to run on its own except for the funding by the government, right? And then by the 1980s, where I joined, that is when the restructured hospitals are basically each hospital actually run on its own. And by the year 2000, the government actually created 2 health clusters. So all the hospitals are separated into these health clusters, each supported by a group of polyclinics to provide primary health care. And the reason for this clustering was, part of it was also to allow for some competition. So there's some competition and to improve quality and so on. However, again, that over time has changed, because some of this competition may not always be good, right? There may be too much duplication of services and so on. So by 2010, it was then redesigned to become regional health systems. Again, each system would consist of primary care, tertiary care, as well as step-down facilities. And from that 2 clusters, we became 6 different clusters, okay, each supported by a few hospitals. Right? And then more recently, in 2017, some of these clusters merged, and now we become 3 different clusters, as I shared earlier. Right, so this is the summary of the last 30 years of what has happened in our healthcare system. So from 1980s, where we go to corporatization, in the early 2000s, you went to clustering, and then in 2010, it was what I call it declustering, or even creating more clusters. And then in 2017, we actually consolidate some of this for better synergies and to also prevent too much duplication. When you have many clusters, I think it can be a bit complicated, confusing for the public. So I think with the current three healthcare group, I think it's a lot neater as well. One of the key changes or challenges in our healthcare system, as I mentioned, the life expectancy is now very high, and with higher life expectancy, it comes with also longer years of disability, right? And so the access to healthcare will increase, and that actually takes quite heavily on healthcare demands. And on top of that, our birth rate is actually very low. So the number of people supporting the senior citizens is actually much lower. So by 2030, actually 1 in 5 are actually senior citizens above 65 years of age, right? And we have basically fewer people to share the so-called with us to support the whole system. So with this, of course, we will need more manpower. So the government actually put in a lot more resources to develop healthcare professionals. So this was a paper in 2017. So by 2020, we need actually 9,000 more healthcare workers, which is why our universities are increasing the intake of allied health professionals. So when I first started, our OT school only taking 20 students, and then it became 40 and 60, and now it's actually more than 100 a year, right? Just to support the demand and the need for more health care workers. The table, as you can see over here, the rising healthcare costs. So this is our annual healthcare spending. As you can see from the chart here, it is increasing very rapidly, right? So from 2010, where our healthcare spending was only 3.7 billion, the projected amount at 2020 went up to 13 billion, but actually the latest figure, the actual expenditure in FY 2020 was actually 16.5 billion. So you can see it's almost 4 to 5 times more just over a 10-year period. And obviously this may not be sustainable if it keep increasing like this. And to make matters worse, the amount of resources we need to put in to ensure cybersecurity. I'm not sure if you are aware, sometime in year 2017, there was a cyber attack on our healthcare records. And because of that attack, well, there was a big revamp in our IT, right? So now we have internet separation. So basically all our office computer where we use for official email that accesses medical record, we cannot access internet with that. So there is increased security measures put in, internet separation, which actually makes work a lot more difficult. Right? Take for example, in preparing for this lecture, right? I can't really use my office computer to prepare because I can't access the internet. So I have to use a separate computer to prepare. And because my separate computer do not have my official email account, I will have to use a separate email account to send the information over. So it makes work a lot more difficult, and also it makes basically even our patients to access the system a bit more difficult because it requires additional layers of security right now. And all these are also costs, right? So yeah, but unfortunately, it's something that we just have to live with because we can't stop all those hackers from trying to, hack our system and so on. Okay, so with this increasing healthcare cost in mind, the government come out with this Healthcare 2020, where there are 7 strategic initiatives. I won't have time to go through all of them, but basically it's really looking at better integration of care, better siting of care, and also building long-term resources, okay, in terms of infrastructure, and more importantly, the training the next generation of healthcare workers to provide this. Right? So the 3 under that priority, okay, there are 3 key shifts, okay, known as 3 beyonds. Okay, so it's beyond healthcare to health, beyond hospital to community, and beyond quality to value, right? So really to actually limit or hopefully reduce the access to actually healthcare, I think the key is really to promote well-being, healthier life, so that there is actually less reliance on accessing healthcare services, right? So there is a big push by the government to focus on providing good health. There are a lot of initiatives such as healthy eating program. There was a combat diabetes program. So all these are really looking at health promotion and disease prevention, which hopefully then would reduce the reliance on having to access healthcare services. The next beyond is beyond hospital to community. So there's a shift to get people to access healthcare within the community rather than to tap on the hospital system, because cost is always high in hospital, right? So to move the care to the community, it brings it nearer to more accessible to the the people, and also the cost can be actually be better managed. So it's actually so the government actually put in a lot more resources, both in terms of building infrastructure services in the community, as well as putting giving subsidy to also improve the overall working environment, as well as salaries for healthcare professionals who work in the community sector. So that actually helped to because traditionally I think a lot of the allied health professionals actually choose to also work in hospital because also the pay is higher compared to community. So with this push to the community, the government actually provides subsidy to make it more comparable for health professionals who work in the community compared to hospital. Okay, and this also involves strengthening the primary healthcare network, so having better communication and also allowing those in the community to have access to medical information and records of patients. Okay, and the third beyond is looking at beyond quality to value. Okay, so again, it's managing costs. As you can see over here, the healthcare expenditure has increased a lot, so there is an increased need to build infrastructure and manpower. But I think the emphasis now is really to look at value. Okay, whether you get good outcome with what you put in, right? So to ensure that people get value from what we put in. These are some of the things that the government again puts in. So using data to guide our practice, so to ensure evidence-based practices, looking at procurement and so on, okay, to actually help to again mitigate costs. Okay, so moving to rehab, again with the aging population, the increased years of disability, there will be increasing resources needed for rehabilitation, right? So one of the new things that was just implemented is called the One Rehabilitation Framework, and this is especially applicable for occupational therapists, physiotherapists, and speech therapists. So this national framework, which we just implemented this year, so we went through 1 year of pilot last year, and we just officially launched a program only 2 months ago. So basically, this One Rehabilitation program or framework is to actually focus on patient-centered care and to look at the patient's journey, again, from acute care right up to the long-term and intermediate care. So maybe just before that, just to give you an idea of how people actually access OT or rehab services. So in general, people have direct access to private rehab services, right? So there is no need for doctor's referral. But if we want to go into the public system, then there would be a referral required. So basically from the hospital inpatient, they can refer directly to the inpatient OT, and any doctor can refer. Okay, so it's not limited to only rehabilitation physicians, but any doctor can refer. And at the outpatient clinic, they can refer to the outpatient services, as well as to the community-based OT through the Agency of Integrated Care. From the primary care, the private GPs, the general practitioners, can also refer directly to the hospital, the therapist in the hospital, or they can actually refer to the specialist first, then it goes to the therapist. So there are various routes for people to access rehabilitation services. Okay, so what the One Rehabilitation Framework focus at, we will have actually a common, well, basically rehab diagnostic group. Okay, so we actually do some triaging to see what tiers of rehabilitation need is suitable for the group of patients. And then there will be a rehab pathway and care plans, and then there are outcome measures for each of these groups. So for a start, we actually have got 6 different diagnostic groups that we implemented the program. Okay, so just to give you an idea, so on the diagnostic group. Okay, so basically based on the diagnostic group, we actually will classify the rehabilitation needs, okay, along the pathways. So just to give you an idea, so each of this diagnostic group in our assessing for the rehab needs, we look at the rehab complexity, the intensity, as well as the frequency. Okay, so this is the chart that summarizes this. Okay, so for someone, say who had a very intense stroke, okay, so they may need daily rehab. So the intensity is the highest at this level. So it's at level 3, and daily D here shows daily rehab. So they will need daily rehab, and this is the siting. So where they will receive this care is probably at the inpatient hospital setting. Then as they progress in the disease, then it may move on to the other settings over here. So this basically help us to actually chart the journey of a person based on the needs on the rehab services. And its implication, of course, then will be occupational therapists and physiotherapists and speech therapists to be competent in assessing care needs for patients. We also have to do standardized outcome measures for each group of patients. So these are the top row here. You can see these are the different conditions. Okay, so these are the six diagnostic group at the moment that we are implementing this program for. And for each group, there is different outcome measures that we have to take. So this table, this part here, the box here, functional domain, quality of life, these are the outcome measures that is taken for all diagnostic group. Okay. And then for each of the specific one, there will be additional outcome measures. So this is also hopefully in the longer term, then we can see that what we are doing actually bring positive outcome for our patients, right? Okay, and the last part about this one rehab program is also looking at manpower resourcing. So traditionally, we have a lot of the rehab therapists, mainly in the hospital setting. With this one rehab framework, it is to actually redistribute the healthcare professionals. So rather than acute-centric care, they are now moving towards community-anchored care so that they are closer to home, and also it will remain more affordable and more sustainable in the long run for patients. Okay, so the implication of this is that again, therapists, okay, not just occupational therapists, but basically anybody in the rehab specialists would need to be better equipped for community-based rehabilitation. So all these have implication on how we train our allied health students. So so the main objectives, hopefully we can achieve through this one rehab program, is that there will be better value for patients, so they get the right type of care, the right timing of the care, okay, and also more importantly, they're able to access rehab care timely and with good value and affordable. Okay, so this is actually a gist. Fortunately, I don't have enough time to go into details of each of the program, but if you can see here, this is basically the summary of this one rehab program and what we hope to achieve through this. Okay, and finally, in my next 5 to 10 minutes, I would talk about some of the training of our therapists. So this is so basically we want our therapists to be future oriented. That is also meeting the healthcare needs at national level. So there is some core sets of standards that we want undergraduates of allied health programs to achieve before they graduate and practice. So this EPA, or trustable professional activities, is something that it's a new approach that we use to bridge the curriculum to the ground practices. So it's originally developed by this person, Prof. Ole, So no, in fact, not just our allied colleagues doing this, the medical school and also the nursing, they are also adopting this same approach in Singapore. So for the medical side, the residency program, they also adopt this EPA in their curriculum. So it's basically to ensure competency. So at the GIS, there are 5 levels of what we call supervision under this competency, under this EPA, right? So at level 1 is basically someone that's probably student just entering, they basically cannot be providing that service or doing that activity, so they can only observe, right? And then at level 2, they may be doing that task, but with supervision. At level 3, with indirect supervision, so maybe a therapist is next door. And then at level, okay, so for students, we basically want our students to be able to perform at a level 3 expectation. Okay. And then once you're graduated, and we have in Singapore, we all the allied students or physiotherapy, supervision therapy students, we have to go through 1 year of conditional registration. So during this 1 year, they'll be working under supervision. So hopefully after that 1 year, they would have attained level 4, which means that they can now practice without any supervision, right? And then level 5 is when they can actually then provide coaching to others. So it's a 5-level supervision. And the purpose of this is then to really know what level of work or task you can entrust to the person to carry out the task safely and competently. So this has been again fully implemented in our OT program this year. So we started again with trial last year, and we actually implemented this year. So these are the 4 core EPAs that we have for OTs. So which is assessing occupational performance of an individual, plan therapy, implement therapy, and then planning for transition care. And then we have another nested EPA, which is to conduct education for caregivers and family. So under each EPA, there is a list of tasks that need to be performed, okay, under each EPA. And then what are some of the things that we use to evaluate that supervisory, okay, on this performance, okay, and then some of the core skills and knowledge that's needed. If there's time, next time I can actually share with some of this document. In fact, one of my colleagues has actually shared the EPA with the Taiwan OT Union just last month actually. Okay, so the EPA is hopefully then to allow us to train allied health professionals that hopefully will be more workplace ready, and hopefully to then reduce the supervisory load for supervisors as well. Okay, so in summary, we want our future health professionals to be able to basically work beyond hospital to community, right? So to play an active role in the transition of care for our patients, and also to anchor care in the community, also to equip our health professionals with educating and motivating and empowering clients to self-care and meaningful occupation. Okay, and lastly, to consider cost, safety, and outcome, okay, as we provide service for our patients and clients. Right. But others are, I think, besides all these technical skills and knowledge, I think ultimately we have health professionals. These are 3, I think, values that we also need to have, right? Care, empathy, and compassion. Okay. So with that, I come to the end of my lecture. I've covered a lot. I know there's a lot of information. I could not go into detail for a lot of the micro part of it. I hope that you actually you have had an overview, and maybe if there's any things that you're more interested to find in detail, I'm happy to share with you over email or some other platform in future, right? So I have some time for Q&A, right? So if there's any questions, please feel free.
Thank you, Patrick, for the wonderful, very information-rich lecture and then talk. And so, well, I think that well, it takes a while for the student to think of the questions and just guide you guys that if you want to ask in Chinese, Patrick can actually.
我尽量，我可以
multilingual.
我现在我华语讲不是很好，那我可以尽量。
Okay, yeah. So before open up the question to the floor, and I'd like to ask Patrick if you can go back to the PowerPoint on the access to OTs. That this is an issue that OTs in Taiwan are very interested in, and I think both OT and PTs, we are working with the government, try to see if we can have direct access to the service. So I think that's one of the.
Are you seeing my screen now?
Yeah. Yes. And that's one that, yeah, well, I think you passed it. It was early, like direct access with private and.
This one?
Yeah, here. So from what I understand is that if the client requires OT that's private, that's sort of a private OT clinic, they have to pay the whole service fee, right? Then they don't need direct service. They do not need a doctor's referral. But then if the agency is funded by the government, then they would need a referral from the doctor or just a referral. Because I mean, from here on the PowerPoint, on the top line, you have hospital inpatient, right? And then the other three are like from doctors. So if you can elaborate a little bit more in terms of the sort of the doctoral referral system and what, especially in the public part, what needs to be, what needs a doctor's order and what does not.
Yeah, so basically any doctor can refer for rehab services. So it need not be from specialists. It could be a general practitioner in the private clinic. They can refer. It could be from the polyclinic, which is our public primary care clinic. They can refer. And also allied health professionals can also refer they can cross-refer certain services. So a physiotherapist, for example, if they want to refer someone for some ADL assessment, they can also do a cross-referral to an OT. So it's not always a doctor's referral, although majority of referral comes from a doctor, right? So if a doctor refers to a physio to take care of someone's walking, and then the patient actually need maybe some other mobility training in a wheelchair, they can also cross-refer to OT. Or if the patient needs some speech issue, they can also cross-refer to a speech therapist. But there is a limited scope. So there is actually a list of things that allied professionals can refer, but majority will still come from referrals by the doctors. Okay. So the doctors can refer to various settings. Of course, the hospital one is usually directly to inpatient therapists, but they can also refer to outpatient service. Both as well in hospital-based or community-based.
Okay, so when a person is in the hospital and then they require occupational therapy, then they need a referral from a doctor or a cross referral, right? Is that what you're saying?
Right.
So the hospital inpatient on your PowerPoint, so the middle part, that it says you have a direct line towards inpatient OT. And the hospital inpatient, you mean the people, the clients in the hospital, not like the referral agency, right? Okay.
Yeah, the client hospital.
Okay, and when you are, and here down at the bottom, the public part, you also have a self-referral. Can you elaborate a bit more?
Okay, so they can also access on the community-based services. Like for example, we have like a people who need assistive devices or assistive technology and they need therapy services, they can actually go direct to these agencies without any doctor's referral. Yeah, so for certain services that are community-based, a person can just go into those agencies to seek the rehab services.
Oh, okay.
Yeah.
All right.
Yeah.
And then the other question is, I know that you have this direct access. You have been this system. You have tried it a few years now, right? It's not like started this year or last year. It started like
Yeah, I think. Yeah, so since I started work, which is more than 20 years ago, it has always been similar like this.
Oh, okay.
So, yeah, so when we first started already, private has direct access, no doctor's referral required. And then in the public sector, it's always it used to be always a doctor's referral. But again, it's any doctor, not limited to rehab physician, but basically any doctor can refer.
Okay, so what about the cross referral and the self referral? I mean, is it just starting?
Yeah, so the cross referral only started recently. I think we started only about 4 or 5 years ago. And also the practice is a bit differing from hospital to hospital for the cross referral part. So not all the hospitals have implemented this. Where I work in Singapore General Hospital, we have started this about 4 or 5 years ago for the cross referral. Yeah, I know in some hospitals they still go through the doctors. So the allied health professional will still approach the doctor to say, oh, this patient may need some other services, maybe you want to refer. Yeah, but for us, because we basically have a discussion with our medical board, and then we came up with a list of criteria for cross referrals. Yeah, of course, when we cross refer, we also usually will inform the original doctor that, oh, we have referred so and so for these other additional services. Yeah.
Okay, and just one last question, and then I will give the floor to the students. For ever since you started the cross referral or self referral, and have you sort of noticed? Have you observed like a change in terms of the services that? Sort of what I'm trying to say is, what are the benefits that you have observed, or what are the challenges that you have observed?
I think the key benefit of this is really early access, because you actually cut down one step. So when we have a cross referral, you actually allow the patient to access the necessary service much earlier, because otherwise the patient will have to go back to the doctor, and that appointment could be a few weeks down the road. And then by the time they re-refer, they have to get another new appointment. So the whole process, now when we have a direct cross-refer, it shortens the process for patient, and which is actually necessary or important in some situations, because the longer you delay, things will have gotten worse. Yeah, so this shortened processes, I think, will ultimately help to reduce costs, because it also saves the patient from going back to the doctor, which will incur additional costs. So it saves costs, it shortens the time period to access the necessary service. Yeah, so I think these are two key benefits that I see, which ultimately actually brought about better outcome and satisfaction as well for patients.
Mm-hmm. So are there like challenges or issues that you encounter in terms of, because it's sort of a change of status quo, it's not.
Okay, challenges. Okay, so far quite okay. We haven't, initially we were a big concern about inappropriate referrals and so on, but I think what we have done is we actually have limited the scope and actually listed very clearly what are the services that are provided by this group of health professionals, and so you actually limit the scope on what are the services that can be cross-referred.
Okay, all right, okay. Thank you.
The volume is still not, but the volume for this cross-referral, of course, is not very high, because I think the good thing is that most doctors actually are quite aware now of what each of these professional groups provides. So usually they will do the direct referral quite accurately. They will actually refer, if this person needs both OT and PT, they will tend to refer to both at the same time. So the need for cross-referral is also not very high per se. Yeah, because most of the time they do get early referral from the doctors.
I see. Okay, all right. Okay, thank you. Thank you, Patrick, for answering my questions. And I was wondering if students, anyone who have questions for Patrick, and if you guys can sort of turn on your camera, I think it'll be good to see you guys.
Professor, we have a question on the chat room.
Sorry, can you repeat your question again?
We have questions on the chat room.
Oh,
Yes.
chat room. Okay. Let's see. Yeah,
Well,
the question about the
if you would
increase
just
in
say it,
health,
yeah.
the health insurance premium. So like I said, because our health insurance, the one that is publicly funded, the premium has been kept very low by the government because everybody actually had to buy it. So the premium actually has been kept low, and we don't have to use cash to pay for this premium. So we use our MediSave account, which is our compulsory saving account, to pay for this. So most and the premium is actually not very high. So for someone below the age of 45, in fact, when they first started work, when they need to buy is about when they're about 20 years old, the premium is only about $50 to $60 a year. But of course, this goes a bit higher. By the time we reach about 60 years old, then we will be paying about $200 to $300 a year. And this is for the basic coverage. On top of that, if you want to buy better coverage, again, we can tap on the MediSave account to pay for that. So far, the premium has been kept affordable. So for most people, when they are admitted to a hospital for a procedure, majority of the people would not need to come up with actual cash payment because of the 3 tiers of payment, or at least 2 or 3 in fact. Okay, so first of all, let's say if I choose to go into subsidized care, I do a surgery, hip surgery, for example, or hip replacement, okay, or knee replacement, for example. So when I go to hospital, first, if let's say I opt for subsidized care, the government already pay about 70 to 80% subsidy. Then the remaining portion, I would pay with my MediSave, a part of it with my MediSave account. And then another portion then will be from this insurance. So the insurance payout is not very high. Unlike the Taiwan system where the full amount is paid by the insurance, that's why the premium, in order to make it sustainable have to be high. Sorry, sorry, I lost screen. Yeah, so because the payout is high, that's why your premium is high. But because our payout it doesn't cover the whole bill, it only covers a portion of the bill. So that's why our premium has been kept at a more affordable level. So it's actually the three parts payment of the bill. Unless a person choose to go private. So even in our public sector, a patient can choose to go into a private room in the hospital where they have a choice of the doctors to operate on. Then in this case, the government subsidy is very low. Okay, so the government only subsidizes maybe 10 to 20%. The other 80% will then come from the person's private insurance or MediSave account. Hope that answers your question.
Yes, thank you.
Okay, then there is about another one, OT services, it doesn't need doctor's referral. So yes, so the same apply for OT and PT and ST as well, speech therapists as well. So basically, as long as you're in the private sector, there is no need for referral. In the public sector, any doctor can refer. And then in certain scope of practice, other health professionals can cross-refer. But this only applies to some hospitals, not all the hospitals in Singapore. Page 13, specialist outpatient clinic. Yes, SOC means specialist outpatient clinic. So basically, these are clinics where people go for specialized care, say like orthopedics, for example. And then these doctors in the specialist outpatient clinic can then refer for outpatient rehab services. In fact, majority, if I may say, almost 80% of our workload for the outpatient clinic comes from the SOC referral. So say OT outpatient clinic or PT outpatient clinic, most of the referral, about 80% or so, or 80 to 90% will come from our specialist outpatient clinic. A small portion would come from the polyclinic, because now of the right citing, some of the rehab services are now actually available in the primary healthcare setting in the polyclinic itself. So there is no need to refer to hospital. So they can actually do it directly at the polyclinic, especially for the physios. So now a lot of the polyclinic has got physiotherapy clinic located within. Okay, what happens if MediSave is used up? Okay, if MediSave is used up, like especially people who are not working because they are not contributing to MediSave, then they will have to set with they will be often referred to a medical social worker where they do a means testing. So if the family or household income falls below a certain level, they can tap on MediFund. So MediFund is basically an endowment fund. So they will then receive free services in a sense. So they don't need to pay. Yeah, so the MediFund is the last level, is when people do not have any MediSave tap on. Also every year, almost every year, but when the economy is good, the government actually will put in money into MediSave account of citizens, especially the elderly. So over the last few years, in fact, we have the government actually putting like a few $100 into each of the MediSave account of elderly above 65 years old, where they, but usually those are the group that need healthcare services a bit more.
And Patrick, if I may, follow up on the PTOT service in terms of the payment. And I think one thing that in Taiwan that our health insurance, one issue that we encounter is that there's no cap on the service that we use. You know, in terms of for the patients, you know, for the clients, you know, they can use there may be a cap on the hospital how much they can ask the insurance to reimburse the service they provide to the clients, but there's no cap on whether how much service I can, as an individual, I can use. I can use as many OTs and as many PTs as possible. So with the population aging, you know, and then with the more like the people, children with people with chronic diseases, illness like developmental disabilities, psychiatric disease. A lot of times there's a big discussion about whether we need to put a cap on this. And so I know that I think the latest I heard from a lecture that in Taiwan, the national average of clinic visits is about like 17 to 18 visits a year. And when we compare it with the sort of the US, or as we are like 2 times of the number, the hospital visit that we use. And so I was wondering, so in essence, I mean, the question I have is that how do you, I mean, you have such a wonderful system, and you know, with easy access and the MediSave, and then so do you have to deal with the overuse or sort of abuse of the health systems?
Yeah, so I think to manage this overutilization, it's really our co-payment system. Okay, because users have to pay a portion of it, especially for outpatient care. So say for rehab, for example, although it's 70-80% subsidized by the government, there's still that cash portion that the person has to co-pay. And because of that co-payment, I think that helps to mitigate the overutilization. Because the MediSave doesn't cover everything for outpatient. So the example I gave just now was for inpatient. When you're admitted for a surgery, then yes, you don't need to come up with much of the actual cash. But once you are outpatient, there will be a co-payment portion. And you cannot tap fully on the MediSave because there is a cap on how much you can use per year for the MediSave account. So let's say I think inpatient there is per day is how much you can use. And then for outpatient services, it's actually only for certain conditions that you can use and only for certain age group. So the younger ones, like for most working adults, we cannot use our MediSave for outpatient services. There's only $300 that you can use a year. For the older generation, they can tap on some special MediSave scheme, then they can use a bit more. So there is still the out-of-pocket payment portion. So people will still be paying 20-30% cash out of pocket. So I think that may help to minimize the use. And to qualify for MediFund, okay, it's actually not easy as well, because you really have to be at a very low income level to actually qualify for MediFund. Yeah, so for most working individuals, there would still be out-of-pocket payment. So I think that the co-payment scheme is one of the main strategy, I think, for managing over excess. Yeah.
You cannot give things for free, and that's basically it.
Yeah, in general, yeah, I think once it's free, people there's a tendency for people to just want to use it.
Right.
Yeah.
Right. And then we also have Professor Wen having asking questions. And Professor Wen, do you want to speak, or do you want to just answer the questions in the chat room?
How did the government audit the reimbursement? Okay, the system audit part, I'm not too sure, but actually every 2 years or so, so we have actually accreditation by the ministry. So they do send audit teams to audit the hospital, and I believe financing is actually one part of it that we will actually look at. In fact, our healthcare financing has always been, the way the government fund the hospitals has always been changing as well. So in fact, just this year, again, now we implemented a new program called Healthier SG, where again, the funding is by per population that you serve. So let's say under our cluster, there is this 1.3 million that you have to serve. Each person, okay, in this is given a certain amount of money. So in fact, the health cluster would tend to benefit if they keep the individual healthy by accessing less of the healthcare services. Yeah, so how the government actually fund the hospital has also changed over time. At one time, it was a block funding. So every year, let's say I give the hospital 500 million to run, and then the hospital just need to make do with this 500 million. But again, that has changed. Yeah, so now it become more based on the individual, because now care is not only in hospital, but also downstream to long-term or intermediate care. So all this will require funding. So the funding structure has changed over time. I believe there is some audit system that they use as part of the hospital accreditation. The Ministry of Health do regular audits as well. And then we also have the Attorney General Office that will also do audits on the ministry. So again, there will be then downstream audits.
Okay, thank you. Thank you. And then before anyone, I also have one follow-up question, because if you talk about that you have private service, some people do pay for private service, and we always notice that in Taiwan as well, in terms of especially for PT/OT, because the reimbursement for PT/OT by the health insurance is so low. It's usually like it doesn't really allow for qualified quality services. In hospital clinic, one therapist often have to see 3 or 4 patients at the same time. To be able, so the hospital will be able to make a profit out of the service. And now we see a trend that more and more PT and OTs, they have private clinics, and they will offer self-pay services. But it's always been an issue about, usually, from our private, from our understanding, the private services usually, they really do have better qualities, because they are able to see one-to-one. But I think that, so that's my, but then at this point, there's no sort of oversight also system in terms of to monitor the private services. And I was wondering how in Singapore, like how, from your observations, how these two, like public and private services, what's the differences, and then how do you monitor the quality of services in for private services?
Yeah, so in our private services, the funding part, basically the public insurance doesn't cover that. So either they pay out of pocket or they get their own private insurance to pay for the private service. And most of the scope of our private services, at least for OT, tend to be more in the pediatrics area, as well as both pediatrics and the geriatric. So like people who need, say, post-stroke rehab, and this group of therapists will do home therapy services at their place. Okay, but so to ensure in terms of quality, basically new graduates are not allowed to go into private practice. So only fully licensed therapists can do private practice. So it means that they will probably have to be in a system where they've gone through our supervisory framework before they get the full license, and then before they can go private. Because not all the private settings would be able to take in new graduates unless they satisfy our criteria to be an accredited center to recruit new graduates. So in general, most private one would have experienced therapists, except some of the bigger private setting where it's a group practice. They need to have maybe at least 3 experienced therapists of at least 4 years experience, and then before they can apply to be accredited center to be able to recruit new graduates. Yeah, so in general, people in the private practice tend to be a bit experienced therapists, yeah, and they tend to serve only very certain segment of the population. Yeah, so in Singapore, very few are in private practice. Only for OTs, only about 10%, maybe only about 10% in private practice. Majority are still in the public sector or in the voluntary welfare sector or social sector. For PTs, so physiotherapists, they have a much bigger portion in the private, especially for sports, physio and musculoskeletal. They have a much bigger proportion. So I think most of it again is a bit more the same thing as well. They will have to satisfy the criteria in order for them to employ less experienced therapists. So that is to ensure the quality part. And then of course payment is either full payment, self-payment or private insurance. So they can't tap on MediSave, MediShield, any of this, they cannot tap on it. It's really full out of pocket.
Right. Okay. Thank you. So anyone else have questions that we're a bit like out of time, and we are already a little bit over time. So if there's no other, I mean, Patrick and I, we can talk for hours, but I don't want to take out any more of your time. So so if you guys do not have questions, Yirong, sorry, we have to take a group picture, you know, so if everyone can open up.
Yes.
Turn on your camera and then.
Yes. Please, everyone, turn on your camera, and I will have print screen. Okay. It's okay. Is it? Right. 希允的脸不见。好，那我解了。1, 2, 3. Wait a minute. Once again. Okay. 1, 2, 3. Okay. Okay, I think the picture is done. And
okay, thank you.
Thank you.
Thank you, Patrick, for your lecture.
Okay, thank you very much. Thank you for your participation and for having me here. Thank you very much.